What are your topics?
Okay, so in the first year, the students learn doctor-patient communication, medical ethics, cultural competence, and professionalism. And these 4 topics are taught first in the classroom in frontal lectures. Then the students break into groups, and each group is taught by 2 physicians. Usually one will be a family physician and the other will be a hospital physician, and they practice these concepts. And they do this with role playing. We have trigger films which we film. We have a wonderful audio-visual studio in the Faculty of Medicine, so we filmed simulated interviews, doctor-patient interviews.
Have you done research on the results of this kind of learning? Do you do testing, or how do you do it? Measure the effects?
Okay, so we're just starting to do it. We have a new system of admission to the medical school, which started actually 1 year before our medical humanities program, so it was 4 years ago. And in this system, first of all, we select the top students, as was before, but among them, we select the ones that we think we have the qualities which will make them good physicians.
So empathy, for example.
So empathy.
How do you measure for empathy?
It's a special system where each student has 8-10 minutes short interviews, and they are standardized interviews. In some of them, they are asked a question which poses a dilemma. Some of them are personal questions, like we ask them to describe one of their achievements or one of their failures and see how they deal with it. And some of them are role-playing. So, and it's usually a dilemma, like we may ask the student to be a pharmacist, and then the interviewer will be a client or a customer who comes with a prescription which is outdated. And the interviewer will ask the pharmacist to sell the medication. We see how they interact. And so they receive 8 different scores from 8 different interviewers, and then this is put into we put this into their score along with their grades.
In what proportion would it weigh against their academic marks?
I think it's 70%, so it's a lot.
That's a lot.
Yeah, it's a lot.
Oh, but you've already pre-selected them for academic grades.
Right.
So I see. So this is a second-level selection.
Right.
I see.
Right. So.
And what would the other 30% still be their marks?
So it's their high school marks and their psychometric exam.
Right.
I think even it may be 75%. I'm not sure about, but it's something in this range.
Okay.
And so we have the first class that was selected in this way. They are now in the 4th year of medical school, which is the first year of clinical studies. So in Israel, we have a 6-year system of medical school, 3 preclinical years and 3 clinical years. And we started the medical humanities program a year later. So we have 3 years that were selected with the new system and had the medical humanities program, and only 1 year which are in the 4th year now. And we're trying to compare them. So we have, there is something which is called OSCE. It's Objective Structured Clinical Examination. So it was developed actually in Canada. It was...
Which medical school? In McMaster by any chance?
Yeah,
I thought it might be. Because McMaster has been at the frontier in Hamilton doing this kind of combination of humanities and scientific
But I think also Toronto had some...
it developed it afterwards, incorporated.
Yeah. And so it was developed originally as an examination in which medical students interview simulated patients, and Usually there are several stations, and the student goes from one station to another, and in each station they will receive a score on their performance. There was something which was developed later, it's called TOSCI, so it's a teaching OSCE. So it's exactly like the OSCE, but it's not an examination, it's for practice. So we have this teaching OSCE in the beginning of 4th year. So this year we evaluated the students doing the teaching OSCE. It has a lot to do with communication, with ethical considerations, with cultural competence. The simulated patients have a role that they are playing, and the students have to interview them. So we did the first part this year. We evaluated the students who were admitted with the new admission system but did not have the medical humanities program, and we are going to compare it next year to those who had both.
So I have to come back next year to figure out the comparison. Well, let me talk about each of the areas. Say cultural competence. Now, you've got certain techniques of teaching cultural competence, and you have an Israeli doctor born a Sabra, say, or somebody else, dealing with an Ethiopian patient, somebody who came over from Ethiopia and is adapting to the Israeli culture, which is a big culture shock just in itself. How do you do that concretely in the doctor-patient relationship? So
many times there is also a language barrier. It's not only the cultural, but many times it could be a Russian patient. It could be even someone who was born in Israel, like an ultra-Orthodox Hasidic or something like this. It could be an Arab patient. Sometimes they do speak the language, sometimes they don't. So many times there is both a language barrier and a cultural barrier. And there is a growing trend now. I know that it's very prevalent in North America, and also it's becoming more common in Israel to have medical interpreters. And they both translate the language, but they also act as cultural mediators. And there are very specific rules how to work with an interpreter. And this is one of the things that we teach the students.
I see.
And at the end of the year, we have an OSCE, as I described before, which is an actual examination at the end of 1st year. And in one of the stations, we have they are tested on their ability to work with interpreters. So we have one simulated patients and one simulated interpreter. And last year and the year before, we had pairs of people with very exotic languages, like Portuguese, like Persian, languages that we think the student are not able to speak. We also had a pair of Ethiopian patients, a patient and an interpreter. And so we see how the students use the skills that they were taught.
Does it affect the relationship among the students? Because you must have Orthodox, even ultra-Orthodox students. I don't know. You have Arab students who are becoming doctors. You have Jewish students. It's a mixture coming through. Does it affect the interaction of themselves in getting this education? Is that part of the intention?
I think it does. Many times people who come from a certain culture, they are really insulted if they say this culture is A, B, C, they try to categorize them. But if you ask them to speak about their culture, usually they're very proud, and it makes them feel good, and it makes other people really understand different cultures better, I think.
And so they function much better as colleagues than otherwise.
Right, and as colleagues and as future physicians.
It'll be interesting to see the measurement of the fact. I don't know. You say in Canada they also do this at cultural training?
Yes.
I'm out of date, you see, on all that stuff.
Right. We have one of our professors in hematology. She immigrated from Canada to Israel about 20 years ago. And she published a story about her experience of telling a patient that they have a lymphoma. And she told this to the patient the way she was used in Canada, and the patient was in total shock. And it was before Yom Kippur, And she called this piece atonement. And she said that after that she understood that cultural competence is not, you know, it's not that the patient has to adapt to the doctor, but you have to understand if you are a physician and you came from a different culture, then you have to understand it. And if you are going to break bad news, you have to do it in a way that is appropriate to the culture that you're working in, not necessarily to the culture that you came from.
I have a story I'll end this section with. When I was a Lady Davis visiting professor here years ago, I brought my Canadian techniques to teaching, which meant I wanted to encourage the students to read the primary text in philosophy. And what it was, as I learned, is the problem with Israeli students is they read the primary text and presume they can interpret as well as anybody. They don't read the secondary text, the very opposite of Canadians. So I had a cultural learning experience. We'll take a break and we'll come back because I want to discuss ethics.
Okay.